Good morning, everybody, and welcome to today's Early Intervention in Psychosis National Network event. My name is Ashley Hose, and I'm a Senior Improvement Advisor leading on the EIP work in Scotland, and I'll be chairing today's session. For those of you who haven't been to a webinar before, the EIP programme is part of the Improvement Hub of Healthcare Improvement Scotland, and the programme of work has been active since 2018. And as a national priority, it's currently funded by the Scottish Government until 2023. The first phase of this work had culminated in a report published in March 21, which had recommended that all NHS boards should establish early intervention in psychosis services, which enable reliable delivery of the evidence-based interventions and minimise the duration of untreated psychosis. And this is because the evidence is very clear that intervening early with the right set of approaches delivered in the right way will lead to significantly improved outcomes for people. So the ultimate aim of this work is to develop, design and deliver EIP services across Scotland and improve outcomes for people with first episode psychosis. So as part of our learning system, we're providing this opportunity for you to hear from Dr. Karen O'Connor, who I'll introduce in a moment. But firstly, I will just run through a couple of housekeeping slides. Next slide, please, Andrew. Thank you. So this session is being recorded and a copy of the recording and any resources will be made available following the session. We'd like you to use the Q&A function to submit your questions for the speaker. And if we go to the next slide, please, I'll show you where that is. So if you're not familiar with Teams Live, it's in your top right-hand corner. There's a little kind of speech bubble icon. If you click on that one, next slide, please, Andrew. And this is what you'll see. And you'll be able to submit your questions shown in the text box there. What will happen is it'll show up in your My Questions tab, and then it will be approved at our end, and then it'll show up in the featured panel. And you can also upvote your favourite questions to be asked at the end of the session. Next question, sorry, next slide, please, Andrew. So this is our national EIP team in Scotland, in Healthcare Improvement Scotland. And I just really wanted to give a big, massive thanks to the team for doing all the background work to make this happen, and also to the National Video Conferencing Services who are giving us some help in the background. So without further ado, I just want to introduce Karen O'Connor. Karen is the National Clinical Lead of the Early Intervention in Psychosis clinical programme in Ireland since January 2020. She's from Waterford and completed her medical undergraduate in University College Cork and completed much of her psychiatry training in Dublin. Karen has spent a year in Origin in Melbourne working in the Early Intervention in Psychosis programmes, which is namely the EIPPIC first episode, and PACE, which is at-risk mental states, in 2008 and 2009. She has a medical doctorate in EIP completed under the supervision of Professor Mary Cannon from the RCSI in Dublin and Professor Andrew Thompson from the University of Melbourne. So Karen is a consultant psychiatrist and the clinical lead of the RISE, which is Early Intervention in Psychosis team in Cork, South Lee. So we're very happy to have you come to us, Karen, with all your knowledge about setting up an EIP service. So Dr. O'Connor will speak for about 50 minutes and we will follow up with a 30-minute Q&A session. So please don't forget to pop any questions in that box. And also, if you'd like to share any resources or make any comments, please pop them in there and we can share them. So Karen, over to you.
Thank you, Ashley. Thanks very much. That was a really kind introduction. I didn't realise I sent you such a long bio. I was like, I should have edited that back a bit. There was no need for all of it. But so thank you very much for inviting me. I suppose I think we're probably in quite similar situations between Ireland and Scotland. So hopefully a lot of what I talk to you about will make sense. And that there will be commonality, I think, around the things that I'm talking about, the challenges we've had, the facilitators. So hopefully it will make sense to you all. I'm sorry, I'm having difficulty moving for some reason. Great. Oh yeah. Yeah. Okay. So yeah. For some reason, when I click, it's not moving the slides. So I'll try and do it from down here. Oh yeah, Okay, so this is just the structure of today's presentation. I'm going to kind of cover 4 areas. The first is just very briefly, because I'm assuming that a lot of the people attending already know a lot about early intervention in psychosis. So I'm just going to do a very quick piece on what is it, why are we doing it. Then I'll tell you a bit about the early intervention in psychosis programme in Ireland. So it's one of 5 actually now national clinical programmes in Ireland. There are national clinical programmes across all of health. So they're in surgery, they're in medicine, and they're in mental health. And we have 5 in mental health, and EIP is one of them. I'll tell you a little bit about the background of that, how EIP came to be part of that, and what's happened since it's become one of the programmes. Then I'll tell you a little bit about our implementation in Ireland, where we're at, and then talk a bit about barriers and facilitators. I think we'll probably have a lot in common around those things. Okay. Sorry, I'm still having a little bit of difficulty moving the slides. Okay. Yeah. I think, sorry, my slides aren't moving. I think I missed a slide. Oh, there we go. Okay. So starting with kind of what is early intervention, I'm sure you know a lot about this, but I suppose really it's around initially early identification and engagement of people with first episode. And then also in Ireland, we're looking at both first episode and then also at-risk mental state. And then it's about assertively following up these people and ensuring they have access to evidence-based interventions during the initial 3 to 5 year critical period, and that there are supports for the individual, but also for their families and their supporters. So the key principles, so I'll talk a bit more about that as I go through, because I'll tell you about the model that we're kind of recommending in Ireland. But there's another bit behind EIP. So that's the bones, they're the operational kind of elements, they're the things that you're targeting and what you want to achieve. But there's a big cultural piece that's really, really important as well in EIP teams. So there's a culture of hope and optimism. I remember when I first started training, so I started training as a psychiatrist in 2005. And I remember meeting a guy who was a very similar age to me. He was doing a kind of graduate entry medical training at the time. And he came in with his first episode of psychosis. And I just remember the kind of the sense that everybody had when he presented was, oh God, you know, things are not going to go well for him now. This is it. His career is over. He's going to have to change track and all of that. And it was just, you know, it was assumed from the outset that things wouldn't be good, that it was a pessimistic outcome. And actually that then meant that really you didn't try maybe as hard as you should have to get a lot of the kind of things that could really help somebody to recover in place. And it's not an intentional thing. It's more around a kind of a cultural attitude. And when I went to Australia, that was in 2008 to 2009. I suppose the big striking difference for me in the early intervention and psychosis service there was that they had this attitude that everybody could recover. Now it wasn't a completely, you know, it was like, I suppose, what would I call it? It was like a realistic optimism. Yes, there may be challenges. Yes, recovery isn't always easy. There's a range, there's a spectrum on this, but actually we really hope and expect that we will get you back to a very meaningful life. And sometimes that would happen very quickly with people. And then obviously other people, there would be more complexity, more challenges. But it was that attitude. The attitude was, we're now going to work with you to try and figure this out. And that's really important in an EIP service, this attitude, this approach of hope and optimism. The youth orientation piece is also really important. You know, trying to help people to, I suppose the majority of the people that come to our services are younger, particularly in men. I suppose it can be a little bit older with women, but just making them feel comfortable, making them feel like this setting is appropriate for them. Service user goals inform all aspects of the care pathway, so it's very much around collaborative working, involving families and carers early and explicitly. I don't know what it's like in Scotland, but in Ireland, in mental health services, I think a lot of the time people feel like families are, it isn't their business. You know, it's more that, like, as a mental health professional, I will engage with the family. but really often it's in a crisis situation, or it's maybe a little bit of information sharing, but it isn't really my role to support the family or direct the family where they can access support. And that's seen as a piece that's separate, and that's different in early intervention and psychosis services. There's a focus on both functional recovery and symptom relief, so it's not just about symptom relief. And sometimes it can be that people may have significant ongoing symptoms, but actually they make a very significant functional recovery. They learn how to live with the symptoms. Whereas I suppose when I came into training, it was very much about reducing symptoms, rather than that broader focus of functional recovery. And then also about addressing comorbidity early. So we know that depression is often comorbid with psychosis, substance abuse, anxiety disorders, trauma. So trying to address all of those things broadly at the outset, and considering them all as you develop your therapeutic plan. So there's international, and in Ireland there's national evidence, and in the UK you guys have lots of evidence. Lots of evidence has been generated out of the UK about EIP over the last 20 years. You know, improving access, so improved detection rates, reduce the duration of untreated psychosis, reduce delays in accessing treatment. Sometimes the delays aren't people coming to our service, sometimes the delays are within our service. Reducing delays in receiving a range of treatments, so not just medication. Yes, medication can be an important component, but it isn't the only component, and people need access to a broader range of interventions. Lower the levels of symptoms. So we know that the evidence shows us that it lowers levels of symptoms, the risk of violence, suicidality and death, increases rates of remission, recovery and relapse prevention. We know that people who get access to an EIP service versus treatment as usual have better functional recovery, and they experience a better quality of life. And there's improved satisfaction and engagement with services. And then we also know the economic arguments. So I'll talk a little bit more about those down the road. But we know that people who get access to an EIP service, so I suppose psychosis is, it's rare. It's not a common disorder. So it's about 3% lifetime prevalence. But for mental health services, it's an extremely, and for society, it's an extremely expensive disorder. And I'll talk about the data we have on that in Ireland. And if we can improve people's outcomes, if we can reduce the risk of disability, it saves our health services massive amounts of money. So it is very much an invest to save programme. I just think that, and you guys might be better at this, but in Ireland, we're not great at tracking that data over time. And so people can be very focused on, oh, the investment is this, but nobody's looking at what the cost of poor treatment as usual is longer term. And we need to be looking at that. So reduced hospitalizations and length of stay, societal savings, retaining people in education and employment, and then societal savings around the criminal justice system. Okay, so EIP is an invest to save programme. This is the way we talk about it in Ireland. You're investing in young people, you're investing to improve symptomatic and personal recovery, you're investing to reduce morbidity and mortality, you're investing to reduce suffering and disability, and you're investing to reduce requirements for long-term care by families or carers, as well as by health and social services. So this is the piece that I alluded to earlier. So there was a report published in Ireland. It was about acute bed usage by the Mental Health Commission, who are our regulators in the mental health sector in Ireland. And they found that more than 70% of people who were admitted to an acute psychiatric bed for more than 6 months in Ireland had a diagnosis of schizophrenia. I think it was about 10% had a diagnosis of bipolar. And this, so the 70%, I just kept it to the 70%, that's costing the Irish government, the Irish economy, it's costing 43 million a year. That's how much it costs to keep those people in those beds for that time. And so I suppose what I would often say is, you know, what's the cost of inadequate psychosis care? We need to look at it from that perspective, because we know that EIP can massively improve outcomes for people. It reduces the amount of people that require this kind of care longer term. And it's one of the main reasons why we need to invest in it. Okay, so that's the kind of EIP initial intro bit. So now I'm going to move on to talking about the programme that we have in Ireland and how it developed. So the clinical programmes were developed in Ireland in 2011. So the idea behind them was, we have the HSE is quite similar to your NHS, and it's a publicly funded health service. We have a difference in our primary care versus our secondary. Our secondary care is funded by the state, but our primary care is actually not funded. It's partly funded by the state. So some people are eligible for a medical card, which means that they get their GP visits for free and they're paid for by the state. But other people, which is around 50% of the population, have to pay privately for their GP care. And there is some private psychiatry in Ireland as well. There are 2 large hospitals in Dublin, but there aren't any outside of Dublin. But the national clinical programmes, the idea behind them was to try and take a national approach to improving outcomes. So improving access, improving quality, and making healthcare, I suppose, more economical. So making smart financial decisions around healthcare as well. So in mental health, EIP was one of the areas identified as a potential national clinical programme. And one of the ideas behind the national clinical programmes is also that you need to do these interventions or these developments nationally, because there isn't great capacity to do them locally. And it's better to do a kind of a national approach. So have a standardised approach. Each clinical programme has its own model of care, which sets out how the programme is supposed to function, what kind of care is supposed to be delivered. And mental health, so the other programmes in mental health are eating disorders, adult ADHD, dual diagnosis, and self-harm presenting to the emergency department. So these programmes were developed in collaboration with the College of Psychiatrists of Ireland, and EIP is one of them. So they were 2011, they were identified, but a lot of the mental health programmes didn't get up and running at all. So there was various things. There was lots of reports being written, and I'll talk a bit about that in a while. Lots of reports, and then there was new requirements for different type of reports, and then another report was written, and then there was a new requirement for another type of report, and a report was written. So the final report that was written was the model of care. That took about 2 years to draft. It was drafted. It was written with a kind of a multidisciplinary expert group, and then it was brought to the College of Psychiatrists, because they're collaborators on all of the programmes. Each of the colleges, so in say medicine, it's the Royal College of Physicians, and surgery, it's the Royal College of Surgeons. So it's brought there to a clinical advisory group. They made edits, and it was kind of finally agreed in 2019, and it was published and launched in 2019. It's available on our HSE website. So if you put in HSE model of care psychosis, this will come up. I wouldn't recommend you read the whole thing. It's very long. It's about 280 pages long, but there is an executive summary which is much more accessible. So in that, I'll tell you a little bit about what that model of care says EIP should look like. So we should have first episode for psychosis services for those aged 14 to 64 for up to 3 years. So care should be delivered for up to 3 years. The at-risk mental state assessments should be available for those aged 14 to 35. Where we've only gotten one of them. One of them has been funded this year. We only have one of those services that hasn't started yet in Ireland at this point. And this bit I think will be very relevant to you guys. So we're recommending a standalone model for urban areas with a population of more than 200,000, but then we're recommending a hub and spoke model for catchments of up to a maximum of 200,000. So more an urban rural mix, or a largely rural area, and I'll talk a bit more about that. So this was so I was on the model of care writing group, and I was on the clinical advisory groups. This issue was a big issue that we struggled with for quite a while. In terms of the evidence base for early intervention in psychosis services, the model that has the most evidence is definitely the standalone EIP service model. However, where this evidence came from was from large population dense urban areas, so big cities typically, and they were typically affiliated with a large academic university. They were co-located with each other, but you're talking about big populations, like a minimum of 1 million of a city, and then, you know, and many of them were much bigger than that. But this doesn't map onto the geography of Ireland. So we have now a total population of 5.1 million. I think you have maybe a slightly higher population in Scotland, maybe 5.5 million. Dublin is our biggest city. It has a metropolitan area of 1.2 million. Cork is our second biggest city, but it only has a population of 210,000, and that's in the broad metropolitan area. If you look at the actual city area, it's only about 150,000. Limerick is the third biggest, 94,000. Galway, the fourth biggest, 80,000. The largest county in Ireland is Cork. I have a map on the next page and I'll show you. And it has a population of about 542,000. And then it has a breadth of about 164 kilometres. And within that you have peninsulas. So it might look as the crow flies that you're not that far from each other on a peninsula, from here to here on the peninsula, but actually it can take a really long time to go from one place to another in some of these areas. So this is a map of Ireland. I don't think I can do pointery thing, but this is Cork down here in the green at the bottom left. So it's our biggest county. But if you try and travel from that peninsula that's on kind of a border with Kerry there, back down across, that could take you like 3 hours into Cork City. So there's big geographical areas, but low populations then spread across these areas. Yeah, so that was a big challenge for us. We were trying to figure out, okay, well, if you put a standalone service, let's say in Cork, so Cork is the area I know best. So if you put a standalone service in Cork, people are not going to be able to travel 3 hours from the end of the peninsula, you know, down in Beara, which is down at the tip, all the way back up to Cork. That's just not going to happen. And we have existing mental health services and they don't function like that. We have maybe five different kind of admitting centres across Cork. And you know, it's not easy to imagine how you'd fit a standalone service onto Cork. Even if it's 2 or 3 standalone services, it's very hard to see how it would work geographically. There'd be huge travel times is the other piece. Okay, so we decided that the best way to go was to look at doing a hub and spoke service. So this gets very confusing for people, like what does a hub and spoke mean? I get very confused about it myself, but I now work in one, so I have a bit of a better sense. So what's the difference between hub and spoke and standalone? So there were a few major differences. One is where the EIP staff are located. So in a hub and spoke service, you'll have some people located at the hub, but you'll have some people located at the spokes. So how this works in my service in Cork is so we have a service on the south side of Cork City. It covers a population of 200,000. We have certain people located at the hub, and then each of the spokes are co-located with a community mental health team. So they're in a community mental health team. So these were the pre-existing community mental health teams that were already there. So they got EIP staff who work between the hub and the spoke. So they attend the community mental health team meetings, but they also come in and they link in with the hub. So they kind of work across both. Some staff spend more of their time out in the spokes. That would be the key workers. They spend a lot of their time out in the spokes and much less time in the hub. Then depending on kind of how this kind of services is structured, are say psychological interventions. They're based primarily at the hub, but they go out to the spokes to deliver care there if that's what's required, or else they deliver it at the hub. They deliver it across both. Similar with family interventions, it's across both. So the interventions in a hub and spoke can be delivered at the hub, but they can also be delivered at the spoke. Certain interventions are more likely to be delivered at the spokes than at the hub. The other big difference between a hub and spoke and a standalone is who takes clinical responsibility. So in a standalone service, clinical responsibility is with the standalone service. So you have a completely separate service that if somebody presents from your local area, they have a first episode of psychosis, they're seen by that service, they say yes, no, they have a first episode, they take them in under their care, and their care is managed entirely with that team, separate from the community mental health teams, the rehab teams, whoever else. They might co-work people and things like that, but the clinical responsibility sits with the standalone team. In a hub and spoke model, there are variations on this, but the version we have right now in Ireland is that clinical responsibility sits with the community mental health team. So the consultant with the community mental health team takes clinical responsibility for the people presenting with psychosis. They get input from various staff across the EIP team, but they all will feed back into the community mental health team consultant, and that's kind of how it works. In terms of staffing, the big staffing difference between the hub and spoke model and the standalone model is the medical staffing. The medical staffing is spread across The hub and spoke, it's primarily in the spokes. In the hub and spoke model, in a standalone model, you have dedicated medical staffing in this standalone service. But there is a spectrum. And so, for example, in Cork, I look after one of the spokes. So one of the spokes is co-located in the hub with me. And over time, we're likely to try and expand that a little bit more, because we have a mix of urban and rural, and it might make sense to do that. I'm not sure we'll ever be able to move fully to standalone though, because you know, some of the people who link in with our service live 60 kilometres away, and it's not realistic to expect them to come in for all their care. So I think there will always, we're going to have to figure this out over time. But from speaking to other services that might have started as a hub and spoke, sometimes they transition across to standalone, other times they end up in some kind of a hybrid, and sometimes it just works best if it's hub and spoke, especially if you have a really big geographical area and low population density. Okay, so hopefully now I won't confuse you further with this, but the hub and spoke, the hub can be real or virtual. So, okay, in Cork, we do have a physical hub. When we started, we didn't. We had meetings that we had in, you know, in a meeting room, and the hub members came to those meetings, but we didn't actually have a space. We did end up then getting a space. So we have both a physical hub, and then we have a membership of the hub group. And I think I've gone through a lot of this already, so hopefully I can answer questions at the end, because this is a bit that people get quite confused about, and it is confusing. So then, just in terms of our model of care, so what are the evidence-based interventions that we recommend? I've alluded to some of them already. So every person who presents with the first episode, they're allocated to a dedicated EIP key worker caseload. These key workers have, so I think they're called case managers in the UK. But they are care coordinators. No, it's case managers in Australia. It's care coordinators, I think, in the UK. But in Ireland, we didn't have care coordinators. We didn't have case managers. We didn't have key workers. So this is totally new, actually, into our system. And so they're supposed to have a maximum caseload of 15. And we can talk a bit about how that works, and the issues around fidelity, and the issues around demand and resources and all of that. So pharmacotherapy, so medication is a component to intervention. Start low, go slow, and try and include clozapine early as appropriate. Then physical health monitoring and lifestyle. This is a big shift for us. Physical health monitoring has not been a core element of how we deliver mental health care. And for me, when I talk to community mental health teams, and I talk to my colleagues, the bit that I get the most pushback on, actually, I usually don't get that much pushback on the other elements. People get that. Now, whether they want them done immediately now and whether they think it's the priority, that's another thing, and we can talk about that. But it's the physical health bit. You really can get a really big pushback. People are like, no, that's the work of GPs. Why should we be doing that? We don't have time for that. And then in Ireland, I don't know if this is different in the UK, but or in Scotland specifically, but in Ireland, our mental health nursing staff are trained separately from general nursing staff. It's a completely different training course, and I think maybe that feeds into it a little bit as well. But this is the core element of our model of care, and it's a core element of what we try to deliver in our EIP teams. Psychological interventions, so CBTP, but then also cognitive remediation, and then that's broadening all the time. So based on what evidence is out there and what evidence is emerging, there's a range of psychological interventions that can be offered. Family supports and intervention are really important. So in Ireland, BFT is the model that we're particularly encouraging teams to use. Not everybody will engage with BFT though, and it's an individual, one family, one clinician intervention. So it's quite labour intensive. We're also now expanding to offer kind of family. We'd love to offer family peer support groups. That's something we have on the agenda, but we're offering kind of psychoeducation groups for families. And that's part of the intervention too, and that suits some people better than the BFT does. But we've had very good experience with the use of BFT, and we get a lot of support from Meriden around that. And then individual placement support. So this is really about supporting functional recovery. So you probably know already about individual placement support, but essentially these are job coaches who will work with somebody around what their employment needs are. What do they want? You know, what have they worked in already? What do they enjoy? What do they not enjoy? What do they want? And then they will support them around interviews. They will have a lot of relationships with employers in the area, and then they'll place somebody and then support them after that. Whereas in Ireland, we had this, our previous approach was very much around training and then placing, but often what happened, it was training and more training and then more training, and then never, you know, there was no work at the end of it. My personal experience of being on a team with two individual placement support workers is that it has been brilliant. There are a lot of young people, particularly men, who will engage with the IPS worker, but they'll engage with me, they'll turn up, but they won't really want to be telling me too much, and they'll keep me at bay, but they will really engage with the IPS workers. It's something they really want, and it really motivates them. And we've had fabulous experiences of people just really blossoming once they got into work. And it might be that they get into one job, they do that for a while, it isn't exactly what they want, but the IPS worker then will help them move to something else. And really it's about building people's confidence, that meaning into their life. And we've had really, really positive experiences of IPS. Just in terms of the resource requirements for the implementation of this model of care, they're significant, but we didn't have reliable data in Ireland around how many people are presenting with psychosis across the country. We know that the incidence varies depending on population density, age of the population, socioeconomic factors, migration. So we commissioned a piece of work to be done by James Kirkbride and his colleagues in UCL, and they're just finishing that at the moment, and it's giving us really useful information in terms of making sure that we resource teams according to what they need. Because the risk is you resource teams according to, well, they have 200,000 of a population, so they all get this, but actually 200,000 of a population in inner city, say Dublin, with very high levels of socioeconomic deprivation, you'll have much higher rates of psychosis there than you will in a very, very rural setting where you might have much lower rates. I suppose the other element that does need to be factored in, though, when you have a kind of a geographical layout like Ireland does, and probably like Scotland does, you know, travel time is really important when you're in rural areas. It can take very long, you know, there are long distances to be covered, and that needs to be factored into resourcing as well. So then just a bit about where are we at with our implementation in Ireland. So currently we have 5 services across Ireland. I have them on a map in the next one, so it's a bit easier. So with 5 EIP services, 20% of the adult population have access to an EIP service in Ireland right now, 0% of children. So we don't have any CAMS EIP service at the moment, but we have one funded. Hopefully it's been funded this summer, and we're hoping we will get that off the ground by the end of this year or the beginning of next year. And there's an at-risk mental state clinic funded as well. They're kind of together. And again, hopefully we will get that off the ground next year. So these are the different teams. So Detect, that's up there with the number 6. So that's, we call our areas community health organisations. So that's CHO6. So that's South Dublin, North Wicklow, and it's a mix of urban and rural, and it's a very large geographical population. So this service covers the whole of CHO6. It's a population of 360,000. They are not adequately resourced to do all of that. And we are trying to add resource every year to build up their capacity. AIST is Irish for Listen, and that is an EIP service on the north side of Cork City. And I'm on the south side of Cork City, so it's the opposite side of Cork City. They've been in place, they've been operating for about 9 years now, a largely urban and highly deprived area on the north side of Cork City, and they have a population of 100,000. And they also aren't fully resourced, but they are getting additional resource in order to bring them up to kind of the staffing that would be required in the model of care. And then there's RISE, the service that I'm in South Cork City, largely urban population, and we have one fully rural spoke. Population is 200,000. And then Sligo Leitrim, that is up there in CHO1, I think. largely rural. There is Sligo town and it has an IT, but a lot of that population is Leitrim, across Leitrim, Sligo, and a largely rural population of 115,000. And then Meath is up there in the orange in CH08, so it covers part of CH08. It's a mixture of suburban and rural, and a population of 160,000. So I'll tell you how we kind of ended up with these different teams. So 3 of them were funded in 2018 as part of a process. So 3 of them were funded and they were called demonstration sites. And this was because of the hub and spoke bit. So the idea was, okay, we're implementing a hub and spoke approach. We know the largest amount of evidence is around standalone. Are we wrong to be doing hub and spoke? Should we actually be going with standalone and just trying to figure out the geography after that? So these teams were funded to start. So that was my team in Cork, Southleigh, then the Meath team, and then the Sligo team. And then a process evaluation of the implementation of these services into reality was also commissioned. And that's that we've just had our final report of that published last week. So, and I can tell you a little bit about that. It was really good to do that. And I'll talk a bit more about why in a minute. So just the other piece that kind of, so you get some funding to set up services, you're trying, you've got this model of care, you know exactly what you're supposed to be doing, it's all been agreed. But then, you know, there are multiple other things that need to be going along in parallel with all of that as you kind of plan how you're moving forward. One of our challenges in Ireland is that our budget is year on year. So there's no multi-annual budgeting. So every year I'd have no idea what money we're getting into EIP for the next year. And you spend a significant portion of your time in my role and with my colleague Rona, like battling to try and make sure that you're prioritised for funding the next year. And it all sometimes feels a little bit like a lottery. And it's not easy then to plan all, you know, to make very clear plans, support the teams as they grow. And we've done reasonably well in the last number of years, but it's unpredictable. I wish it wasn't so unpredictable. But I suppose a piece that you really need to be developing as you go is around the workforce. And I know you have workforce challenges in Scotland. We have very significant workforce challenges in Ireland, but the stuff that we can do things about are we can try and get people more interested in EIP. And then when they do come into teams, making sure they have really good induction and that they're well connected into the broader EIP network. So we have network days every 3 months. We do them online. That was a big bonus of COVID, that we actually moved online, and I think we'll continue to stay online with that. We then prescribing, so we've developed these induction modules around this, and then we also have the network days, and then actually all of our staff who join into an EIP team get access to these modules developed in Origin. So Origin and Melbourne have these excellent teaching modules around a whole range of things. I don't know how many they have like 50 of them or something. So our staff get access to 6 or 7 of them at the outset, and then they can potentially get access to more afterwards if they want them. And they introduce them to a lot of the basic principles around EIP, around dual diagnosis, around crisis management, around case management, all of that. So yeah, and then so just we've set up different things. So we have the EIP key worker role. I mentioned this earlier. This is totally new to Ireland, and it's been challenging on a number of fronts, but hugely rewarding on an other range of fronts. I suppose from the implementation report, I'll tell you about the kind of findings there, but one of the huge findings was around the key worker. People found the key worker invaluable. Service users found it invaluable. Their families found this role invaluable. But the role is different to anything else we have in our health service at the moment, and that's creating some challenges for us. For the key workers themselves, they were coming into a role that kind of was new. It was written in the model of care. What does that mean? Most of us really only learn about stuff, you know, through experience. So we've set up a virtual supervision group that runs. There's 2 groups. They run once a month, and it's done with somebody who has a really deep experience of EIP, key working, case management, care coordination in Wales, and so he links in with them twice a month, and so each person can attend once a month. So that's been working really, really well. It's an opportunity for them to network with each other, problem solve, and then also they have this supervision structure from someone who has a lot of experience in this area. CBT for psychosis, this was an area as well we had significant gaps in. So we had people who were interested, and they had gone off and done their own training on this. but we didn't have an easy way of supporting people who might be interested in developing expertise in this area. So in collaboration with Trinity and then University of Galway, there was a new program was developed. So it's for people who already have CBT, are qualified as CBT practitioners, but now they can do this 9-month program around psychosis to develop that psychosis expertise. Then physical health screening and intervention, that's a new initiative. We got some funding for that last year. It was once-off funding. There's been kind of pots of this kind of once-off funding kind of emerging last year, and this year came out of COVID. And so that's a bit we've really struggled with. I flagged earlier, this is a cultural shift for our teams. It has been difficult. So what we saw that there was a project in Oxford where they had used these point of contact testing machines where you just do a finger prick and then you can do the HbA1c and the lipids from it and get the results within 10 minutes. And so we're currently training staff up around that, and we're introducing them into our teams. We're hoping it has an impact. And then the individual placement support, we have network days. That's how we kind of explain to people what that's about and try and build interest in it. So how did the implementation go of these 3 teams? So the funding was awarded in January of 2018 and hasn't been entirely straightforward since then. In 2019, so there was a whole piece around we were recruiting into roles that were new, so that was challenging, and we had HR issues around that. And then we had a change in the kind of CEO and the HSC, and there was kind of things changed about how you could use funding, and that delayed us a little bit as well. But eventually we have got all 3 teams up and running, and all participated in the evaluation. So the Cork team that I work with, we launched in May 2019. We got 11 staff to do that launch, and we've gotten some additional staff since then to manage the increasing caseload. So that was the kind of year 1 funding, and we've gotten year 2 funding and year 3 funding. Sligo launched in October of 2020, and then Meath hasn't formally launched, but that's more of a kind of a logistical thing. They've been in operation since July 2021. Okay, so this is just Nicola, so the evaluation that was done, the external evaluation that was done of these 3 services was done by Trinity College Dublin, and Nicola was the postdoc on that, and she shared this slide with me, and I think it's really useful because it really speaks to me anyway. You know, implementation is the car without wheels sitting on a bunch of plans, and then there's more plans, and then there's more plans, and then there's more plans. The transition from plans into implementation, into the real world, into an already very complex health system that has a whole set of its own problems and holes, and they're slightly different across different areas. You inherit all of those when you bring in something new, and there's a resistance to change that's always going to be there. It'll be worse in some areas than it will in others, you know, and it just makes implementation a really challenging thing, but still a very worthwhile thing, but challenging. And I think those types of challenges will be experienced no matter where you are, no matter what health service you're in. Even looking away at the greener hills in another country, you talk to them and it turns out everybody has their own set of problems. Sometimes, yes, sure, they're more difficult in some areas than others, but there are challenges when you try and implement new things into existing health systems. So I'm going to talk a little bit about the barriers and the facilitators as we've experienced them over the last number of years. So the barriers, so funding, so the need to secure multi-annual ring-fenced funding, that would make our lives so much easier. If I knew that for the next 3 years we were getting this every year into EIP, well then we could plan with confidence. But what happens is the budget was announced last week. It was only announced this Tuesday. I still don't know what we've gotten out of that budget. There has been some allocation to EIP, I know that much. There'll now be kind of weeks and weeks possibly of back and forth before we find out exactly what we've gotten. And then we probably won't be allowed to draw down on that money until, you know, a quarter of the way at least into next year. And so you're kind of always chasing something. It's just very hard to plan. Whereas if I knew, you know, over the next 3 years, this is what we're getting every year, then you can say, right, okay, what are our priorities? What's the best way of doing this? And you can lay it out kind of course, it won't all work perfectly like that, but, you know, you can get a pandemic in the middle of your 3-year demonstration site. All of those things can still happen, but it would just be a lot easier to plan. It's a real frustration for us. It's probably different with you guys, but it's a real difficulty for us. Changing the status quo was hard, it just is. And so when I came back from Australia, I was initially employed to set up a crisis team, and I did that. And, you know, and then after that, it was the EIP team. So I just know that changing things is just hard, and not everybody will have the same priorities as you, or think that this is the thing that needs to be done now. Most people with EIP think, oh no, this is definitely a group of people that I feel need more support. I recognise, you know, that this all makes loads of sense. Early intervention, you know, that this makes sense to me. But you know, maybe not this year. You know, maybe next year would be a better year to do it, because we have all these other challenges this year, and so maybe it should be next year, and then it kind of carries on with that. I think you need, and we'll talk about this in a minute, you need, it requires a lot of tenacity, it requires a lot of support, and you have to be able to tolerate uncertainty. You have to be able to tolerate that, okay, this is the right thing that we're doing now, but we'll need X, Y, and Z down the road to make sure we can sustain this. We're not sure we're going to get that, but you kind of need to keep moving on, because if you don't move, then very quickly people will start saying, well, sure, I knew this wasn't going to work. No, I knew all along this was never going to work. It was a lovely idea. It works very well in Australia, it works very well in England, Canada, America, but we're totally different. Ireland is different. We have a different set of needs. I knew it wasn't going to work. So, you know, you need tenacity, you need to tolerate uncertainty, you need patience, and you need a lot of faith, and you need a lot of other people. You need a collaboration, and I'll talk about that. One of the things that we would have experienced with our demonstration sites particularly was the pragmatics of implementing. Sometimes the clinical leaders needed skills that they wouldn't be things that we would have known or been good at, or really had any expertise in, or it wouldn't really have been part of our role. So, for example, there were challenges around HR. You had to lead the resolution of those challenges locally yourself as a clinical lead. It wouldn't be my area of expertise. Things around IT, there were challenges around IT. We're still in paper in Ireland. We don't have an electronic health record. But things like that, you know, so you had to kind of, and if you weren't willing to do that, well, then you could get stalled for a really long period of time. And so you kind of had to kind of roll up your sleeves and kind of learn about things that weren't necessarily your area, but you needed to, or else you weren't going to move on. It's not an appropriate use of clinicians' time to be doing things like that, but it was what we had to do to get things ahead. Stigma is a huge problem. I don't know if it's different in Scotland, but in Ireland it's a big problem. Psychosis is poorly understood in the general population. In Ireland, a recent study looked at, you know, how the media speak about psychosis, and 72% of the references to psychosis in the Irish media were in the context of perpetrator violence. So that's kind of what comes to people's mind when they hear about psychosis. They don't think about recovery. They think of fear. They think of a lot of negative things. They don't hear very often from people who have recovered, who've done really well. And therefore there's kind of a limited public, and then because of that, political profile for psychosis, which can be very challenging. Because you're competing with lots of other demands when you're trying to get resources into EIP. Recruitment staff were very interested. This was our experience. We had loads of applications. We had no problem recruiting staff. The problem we had was that they often came from our existing services, and then you left gaps in the other parts of the HERT services. That is a very real challenge. And we did our best to work with local teams to try and manage all of that so that we got the best balance that we could, but it's a real challenge. And then COVID accelerated that got a lot worse because we had no movement in and out. We've actually had a bit of a moving out from the health services post-COVID. So often unspoken barriers, you know, this group are already getting care, so why do they need EIP? This is a super specialist ivory tower type thing, and what they're getting is good enough. There's a therapeutic nihilism, a kind of, well, look, I'm not convinced that doing all of this will make a big difference. Look, maybe it'll help a bit and maybe people will like it. I'm not convinced it's going to change the outcomes for people. And then if there isn't a lot of experience of working in EIP, then, you know, you need experience. You need to have seen it with your own eyes. You need to have experienced it sometimes. Some people do. To really believe that it's going to work. Change is hard. Some are open to it, others aren't. They're early adopters. You need to run with them. There are laggards. They'll always be there. You do your best to kind of communicate the message in a simple way over and over again. You hear what people's concerns are. You do your best to engage with them and then try and roll with the resistance. I suppose the other thing that we've come to really realise and try to emphasise is that EIP isn't just about improving access or reducing delays or giving people access to evidence-based interventions. It's also about a culture change, and that's really beneficial to the wider health service more than maybe we appreciate. So new EIP teams, they're not being developed on a greenfield site. They're landing in on top of an existing healthcare system, which has problems and struggles, and they will inherit those struggles, and then they have to do new stuff on top of it. It's challenging. There's tensions between doing something good enough and doing something in line with our model of care, for example, or what's the ideal. That's a difficult line to walk sometimes. I suppose our experience is you need to start somewhere, but you can't, you know, have a man, a dog and a chair and call it an EIP team, because it's not an EIP team. And then everyone will say, well, that's not working at all, it's useless. You're like, well, no, it isn't working because it isn't what it's supposed to be. There is a certain amount of fidelity that has to be there. But there's a balance with realism. There's a balance with the context you're in. We've kind of, I'll talk to them, we've brought in various things that are helping us around fidelity and quality improvement. And we've really tried to have that as a focus from the outset, and to help us to move closer to where we should be, to where the ideal is. Energy enthusiasm is really important, but you need to build a coalition. So you may have a group of people who are really committed to this. It's a marathon, it's not a sprint. You need to pace yourselves, you need to connect widely. You need to build a really broad coalition, and ideally it needs to be people who've lived this, who've loved people who've been through this and who learned this. So service users, families, the voluntary sector, we have really good relationships with Shine and mental health reform, for example, in Ireland. They've been great allies to us. Academics, we have really good connections with a range of academics in Ireland. Ireland, in terms of our academic profile for psychosis, it's actually very high internationally, but they tend to all be in different institutions, and we've only more recently they've set up an Irish Psychosis Research Network, and they've increased their collaboration, and they've now recently there was a grant gotten from our Health Research Board to support 5 PhD projects across 5 sites in Ireland, which is really, really good. Your academics can be really helpful to you. In terms of, you know, they often already have a certain profile, they have access to a certain kind of arena, and them speaking up about psychosis can be really, really helpful too. Sometimes they're not as connected in with the political side of things, or maybe the clinical side of things, and so trying to bring in those connections can be helpful. And then clinicians, you know, obviously hugely important, and providing people opportunities for education and networking is really important. You know, knowing your landscape. So who has the power? Who makes the decisions around funding? Who makes the decisions around allocations? Who can prioritise, you know, your recruitment? Who can prioritise finding solutions to the problems that you have? Who's listened to in your area, in your arena? Are there other projects around, not just in mental health, but in health that have been successful? Can you learn from them? And then I have found personally, I have to adapt my messaging to my context. It's not that I change my message, but different people have slightly different interests. You know, some people want to know about the service user impact. Other people are much more interested in the economic impact. So you kind of have to have your messaging. You need to tailor it a little bit sometimes to the audience that you're meeting. And this is something that we definitely learned from the evaluation. The evaluation report is available online, so you can access it if you want. There's an executive summary at the start with all of the recommendations. We joined the NCAP audit in England and Wales last year. We did that last year and this year, and that's been really good for us. You know, we're obviously at a much earlier stage of development, so comparing us to England and Wales, you know, we're further behind. But it allows our teams to kind of benchmark ourselves against, you know, what's the kind of the standards set out in NICE, what are the standards set out in the NCAP, and it's useful for us locally then to say, well, look, this is our national report on Ireland and where we're at. This is better this year, this is worse, you know, and this is what we're doing about it. Gives a certain, I suppose, objectivity maybe to the work that's being done. And then the evaluation report, I'll talk a little bit more about that anyway in a second. We collaborate with a variety of people. So we collaborated with Shine, who are in the voluntary sector in Ireland, but they were originally set up as Schizophrenia Ireland, and they changed their name to Shine maybe more than 10 years ago. But they have been collaborating with us a lot. They provide clinical services to people in the voluntary sector who have lived experience of psychosis, and also their family members. And we found that we've kind of very similar values, and we have very similar objectives. And so we collaborated with them to get to do a survey online around the lived experience of living with psychosis. Something I think that you are a good bit ahead of us on, and something we've struggled with, is getting the lived experience voice out there. we have some platforms on which people link in around that, but it isn't a voice that's heard very much in Ireland. And so we've been really working with Shine to try and support getting that voice out there. Because it's very easy sometimes to say, well, we don't hear anything about that. So say during the pandemic, there was an awful lot on the radio about eating disorders, and there were huge gaps in eating disorders services in Ireland. But they got a very significant investment then last year because there was so much public pressure. It was all over the media. Nobody rings up radio stations or talk shows to talk about psychosis, not in Ireland anyway. And that's a piece then that people can easily say, well, I don't hear anything about this. Let's say it's fine. Everything's fine. It's grand. This isn't a problem. So then sharing the vision, this is our national mental health policy. We are in there. So that's another platform that we try and use to progress things. So I'm nearly finished now. So what have we learned? So EIP works. So from the evaluation report, this is kind of the bottom line of what the evaluation said. EIP works, it reduces admissions, it reduces relapse, and it is associated with better outcomes for people. Service users and their families prefer it. That comes through really strongly. Staff much prefer working in this way. They find it really innovative. Yes, they found it boundary kind of stretching. They found, people would talk about having to learn new skills, a lot more crisis management stuff they mightn't have been used to, but then they really enjoyed it and they find it really a really nice way to work. The barriers that we had from that evaluation report were within our health system. So funding, the funding was there, the funding was gone, the funding was used for something else, the funding came back. That was going on for 2-3 years during it. HR processes, we have very different HR processes across the country. So from the time someone interviews to the time they start in the post could range anywhere from 3 months to much more commonly 1.5 years. And that was a huge problem for us. And the delays, we couldn't figure out where were the delays in the system. There are rules around some of that, but the rules aren't kind of uniformly applied, and that's very challenging. There are reasons for that. It's because there are gaps and lots of other things, but it's just very, very challenging. And we have very poor IT infrastructure, which I mentioned earlier, and that really needs to be addressed because a lot of the data that we collected was collected with assistance of other people. So it was like Trinity did it for the evaluation, NCAP, but actually our own data collection systems are very, very poor, and data really helps you to counter the false narratives. I think I've said a lot about that already. Listen for the narratives. That's the other thing, that resist change and be prepared to counter them. It's a bit like whack-a-mole. So, I think I have it here, EIP teams are ivory towers, they're too specialised. We can only resource the status quo or new developments. This is a real thing in Ireland. We can only keep things going. We can't do anything new, or else, oh no, we're doing all new things and we're not, we do this kind of polarisation. The polar is not helpful. We need to be in the middle. We need to be doing both. Not this year, next year I said that. And then it works in other countries, but it won't work in Ireland. The other thing is you need allies outside of your health service, or people who are part of your health service but can speak in areas you can't speak. So as a HSE employee, I'm limited in certain things that I can say and who I can say them to. But if you have people who are in the voluntary sector or with lived experience or with family members, they can speak in fora that you can't speak. And they can speak with much more authority, to be honest, in area, on all of this that you can't, and they can get their message across much better. And even trying to kind of communicate more broadly with like GPs. GPs are very good allies for us because they recognise the impact of the programme. Physical health, trying to get other people to recognise the value of maybe elements of the programme, if it's not the whole programme, if it isn't psychosis as their focus, and then speaking to that in different arena. And just that, it has an impact beyond just psychosis care. It's a progressive way of working. It impacts the wider health system. It reduces social welfare demands and employment, and you need to share the messaging, broadly around that. And then, what's the cost of not investing? I think that's me. Yeah. So I think I've gone through all my 4 areas, and then that's just my final slide. So I'm very happy to take questions if there are questions. Will I stop? I'll stop sharing. Yeah.
Many thanks, Karen. That was a really, really insightful presentation and a really good overview of what's happening in Ireland right now, which is in some ways a lot of what we can relate to in Scotland. And I think it's, your message there is really clear about having a lot of resilience around this, and just because it's a new service and because there may be other challenges that come at the end of it doesn't mean it's not worth the time and the effort to overcome the other challenges that may come around a service like that. And it was certainly really insightful to hear that. There's some questions in the Q&A box, so I'm just going to pass over to Dr. Susie Clark, who's the psychologist in the Esteem service in Glasgow, and Susie's one of our clinical leads in the EIP programme, and Susie's just going to facilitate this Q&A session. So over to you, Susie.
Hi, thanks, Ashley. Thanks, Karen. That was fascinating and so validating. It's really interesting to hear the kind of arguments and challenges and how much they've been part of my career, I think, in Glasgow, but also, you know, I'm still hearing the same things I heard 20 years ago, and things haven't moved on. I think I really concur with everything you've said about, I suppose, just the complex system that you're developing these services in, the value of the key worker role, the importance of the lived experience voice, and the fact that EIP is very much, that's the model, and that's really important. And I think politically, it's that's something that is sympathetic, you know, at a political level, the fact that as a programme of work, we're very much embracing lived experience and keen for people to really influence the direction of travel. And that's really, really positive. And it's really been so interesting to hear your thoughts. So there's quite a few questions. One person asked for clarity about an at-risk mental state, and just what that was. We're not funded for that in Scotland at all, or Glasgow. So it's not maybe so much knowledge about that here.
Yeah, so that's so I suppose it started out of work looking at, could you identify the prodrome? So it's work. So the at-risk, they use different terms. There's the ultra high risk, the Australians use that term, and then the at-risk mental state is kind of more of a European term and an American term. In America they use, I think it's clinical high risk. So there's lots of different terms for the same thing, but essentially what it is you'll have young people, often CAMS, and then maybe a little bit later presenting saying, you know, sometimes they don't even say it, but when you explore in detail with them, it emerges that maybe they've been hearing a voice. They've heard a voice or a noise. Maybe it starts off as a noise, maybe 3 times a week or 2 times a week. It's worse when they're stressed. And then maybe they go through a period of stress and suddenly it's up and it's much higher, and they're seeing maybe a shadowy figure in the corner of the room. It's not every night. It happens maybe once or twice a week. And then maybe they start to think, you know, oh, you know, I feel like it's really weird that song keeps playing on the radio. Like that, there must be more than a coincidence in that. And then they start thinking about that more, and then they start to see connections with other things. But they're not at the level of where that's happening every day. So they're not hearing it every single day, or these psychotic-like experiences aren't happening all of the time. But they're above a certain threshold where you can consider this person to be an at-risk mental state. And I suppose in the original research around this, they would have said about 40% of those people who come forward and help seek transition to psychosis. It looks like it's lower now. It's probably 20 to 30%. And so I suppose in Ireland, we are interested in trying to capture that group too and support them. And really the interventions, it's not medication. It's really about helping them manage their stress. It's really about helping them manage whatever is bothering them. And sometimes they'll be depressed, or maybe they have an anxiety disorder. You know, you'll manage that, but it's not antipsychotic medication.
No. Yeah, that's really helpful. And I mean, the truth is, we do see some people in Esteem who are like that, who come in for CBT, but you know, officially we're not funded for an at-risk mental.
Yeah.
There's another question there around about hub and spoke, and kind of feeling that might be a good model for Scotland, and we've certainly identified that will work potentially for certain areas of Scotland, and particularly facilitating continuity of care when people are being passed back to services. And a concern about the number of people that might be discharged from mental health services after an EI service. The figures are quoted from Oxfordshire, discharging 83% of people to GP. And just
we're looking at about, like, I think we're only at the point of just starting from Cork. We're just discharging, so we're just over 3 years now. I think it's probably about 60, maybe it's 60% are going to the community mental health team and 40% are going to the GP.
Yeah.
Really how we do it is with them. We do it with them. We say, what would you prefer? This is what's available. You can do this or you can do this. And then we're trying to link in with other organisations like Shine, who will do individual work with people as well in the community. They can come back.
Yeah,
you know,
no,
if
absolutely.
So
I mean, to be honest, that's really interesting. So I would say in Glasgow, we when we were a 3-year service, it was probably 50-50. Now that we're only a 2-year service, it's probably 60 to CMHT, 40 to GP.
Yeah.
And actually our problem's been getting CMHT to take some of our cohort on because they're doing so well.
Yeah.
Yeah. So it's not a major concern for us, I wouldn't say. The next question's in relation to hub and spoke. Is Sligo a hub and spoke model or a standalone service?
It's so Sligo, Meath and Cork, where I am, we're all hub and spoke. And I actually even detect with the 360 is currently hub and spoke because they're not resourced enough to go standalone. They will go standalone in time. Yeah. Yeah.
And that makes perfect sense, I think, for large, chunks of Scotland, particularly where you have an urban centre, maybe where your inpatient beds are, but actually really quite dispersed rural populations. Obviously, Glasgow's a big urban area, and right along the Central Belt is large enough and busy enough areas for specialist standalone services. But once you get up to the geography of the islands and highlands, it's really very dispersed. And actually, I think COVID's been a positive thing in that regard. We're much more au fait with video technology and digital resources and getting supervision remotely and that type of thing. So I think that holds some promise for developing EIP services in more remote areas. So it's interesting.
And family groups, that's the big feedback we got. People were so many more people attended that wouldn't have before. And then we had family members from London, and because they could just video call in, which we would never have thought about. So it's good.
Yeah, no, absolutely. We have that too. Our attendance has been great. How do the service users feed in?
So their feedback, is it into the
service?
Yeah. So we have so locally, at each team, we're trying to develop, we're behind you on this. So we're trying to develop kind of advisory groups with each local team. In Cork, where I am, we're just starting that now. So we tried to do it during COVID and it was online and it just didn't really work that well. And we felt that people probably needed to meet each other face to face before. So we just have our first group just starting now. And they're a mix of graduates from the programme who just graduated from the programme, and then some people who are still in the programme. And that's where we're at. Nationally then, we have on our overarching implementation group, we have service user representation on there and family member representation. That was actually quite hard to get. We had to do quite a few rounds before we could get people involved, but we have that now. And then we have a number of organisations who would also advocate. So they're advocating from that perspective as well.
Yes, I think that helps actually, because we've done lots of different things over the years, but actually find that with a 2-year service, some young people don't want to get involved in kind of developing mental health services. They just want to get on with their life. And actually, eventually, I got external consultation about why could I not get these lived experience groups up and running within Glasgow? And actually, we have an organisation called the Mental Health Network in Glasgow that does a lot of the service user involvement for the board. For mental health, and our service users, if you like, are signposted there, and then they hold, and there's lots of advantages to that being in a third sector organisation. They can say things that we can't say, but also there's a support network there as well for service users, and they can dip in and out of what they need to do. So so that's interesting, but it does take a little bit of thinking time to work out how to develop these things.
And to sustain it,
and sustain it, yes, exactly. Has there been challenges working with different psychiatrists in the hub and spoke model? And how have you managed those?
So with lots of diplomacy, and I think because I think over time it evolves. So when you start, I suppose there's an element of picking your battles when you start. They are all really overstretched. Everyone's overextended. They're doing the best they can. And so if I start launching in at people, why did you prescribe this? And why did they're clinically responsible for that patient. I have no right to be doing that. So, there's a balance with all of it. So what we would have done is quite a bit of education, just telling people, presenting things at case conferences, doing it that kind of way. We've developed some local guidelines around prescribing in Cork. And then nationally, we're just about to set up a national group to develop national guidelines. I do a good bit of training with, say, the College of Psychiatrists in Ireland. So all of the trainees now have access to, like, you know, modules that we have co-developed with service users around psychosis, around medication, all of that. So I think it's coming at it from lots of different angles. I think going head to head with people doesn't tend to work very well. And, you know, I've seen it improves over time. I would say it has improved over time. And I think, you know, again, it's that piece of engaging with the person. What's the problem? You know, trying to understand where they're coming from. And sometimes they're coming from a place that you just didn't expect them to be coming from. And it can be easier than you expect then to kind of address that. So, yeah.
I think particularly because EI services are so good at assessing side effects, and the side effects are the main reasons for discontinuation of medication, and that can really influence the prescribing cancer, because
yes, exactly.
So that's really helpful to hear. I think that's something that we're trying to work out, because of course Glasgow's such a standalone established service, and actually a lot of the services that will develop in Scotland will probably be hub and spoke, not all, but some of the northern ones. And how does that work?
I think it's bit by bit, and again, it's the experience. Then once people change maybe their prescribing practices or whatever, and they realise, oh, it does work, you know. Abilify does work. We don't have to use olanzapine first line, you know. You know that, you know. Then people get more comfortable with it. It's often not sinister reasons. It's just experience. It's just habit, you know.
Yes, no, I can see that, and I think there is a need for some training with the general adult people in some of the boards that are kind of doing a bit of a hybrid model with medical staff coming from one bit and everybody else in another bit. There's another question, or reflection really. I work in the third sector supporting people who've experienced psychosis. Your presentation is inspiring. I can see huge benefits to be gained with the hub and spokes and the CMHTs, for example, sharing knowledge, culture change, stretching boundaries, and bringing the CMHT and third sector along with you. So just a message there.
That's really nice. That's what the teams say. That's what the key workers say, actually. They say initially they feel like they're the sole person carrying a flag, and then as it goes on, everyone starts getting closer together. And actually the continuity is really helpful after the 3 years.
Yes, no, I'm sure. There's a question around about BFT becoming couples therapy. How can family work not become a couples therapy?
Yeah, so that comes up sometimes. The clinicians are quite clear on it. They will make a recommendation if they think what it needs to be is couples therapy. They will do the initial kind of appropriate stuff, and then they will make a recommendation that people do that, and they'll tell them where to go. That's kind of how we do it. We signpost people.
And the next question is, could you say a little bit more about plans for the CAM service and what that might look like?
Yeah. So what we've initially got funded is an at-risk mental state service that we're hoping then will transition into a CAM service. So actually, this is actually a very good question. I should have flagged this. The person who was going to be leading this service is leaving us now, and he's going to become a professor of CAM in child psychiatry in Edinburgh. His name is Ian. So Ian has been a huge advocate in Ireland and internationally for psychosis in CAMS. He's been fabulous. He's on our implementation group. He never lets us forget the under 18s. This is about figuring out what's the thing that's likely to you kind of get the best hold. So our CAMS people were saying to us, we don't see much psychosis. It's not an issue for us. We don't see this as a priority. But what we do see is an awful lot of young people who hear an occasional voice or have some odd ideas. We think it's personality, or we think it's whatever. We don't think it's psychosis, but we wouldn't mind if someone did a kind of an assessment of them and gave us some feedback. So our sense from that was that we'd be better off going into CAMS with an at-risk mental state clinic and offering that assessment piece and feedback. So we'll pick up the psychosis cases, and then also you'll hopefully be supporting the staff around maybe conceptualizing some of the psychotic-like symptoms maybe in a slightly different way. That's what the staff in CAMS wanted from us, much more than they wanted psychosis team. So that's how we're starting, and then we're going to grow it from there. That's kind of our plan.
Yeah, that's interesting to hear, actually. I mean, to be fair, the majority of contact I've had over the years from CAMS has been requests for teaching, actually, and how it presents with, and you know, how psychosis presents in young people. I think our interfaces are still not perfect with that, and because I mean psychosis is much rarer under 18, so often I think people come to us actually still quite late just because they don't get picked up. It's not recognised.
We are hoping. Yeah, we are hoping that our existing teams, if we get the funding this year, will start reaching into CAMHS, and how we're planning on doing that would be co-working, so that the clinical responsibility will remains with the CAMHS consultant, but they would get an EIP key worker dedicated for the CAMHS cases, and then they'd have access to everything else, the psychological intervention, the family work from our main team. And then if it was appropriate to co-work some of that, we would co-work some of it depending. So it might be more appropriate that they see the psychologist on their team, but we would provide supervision or whatever. That we're kind of we're figuring it out. That's how we're kind of doing it at the moment.
Yeah, okay. There's another question saying, have you asked the consultants in the hub and spoke service whether they would prioritise resources going to early intervention or going to community mental health team services, for example, staffing? It's pointless providing high quality early intervention if patients with severe and enduring disorders are then given poor mental health care ongoing.
So I suppose I haven't asked it directly, but what has happened in my own service is that when we recruited those 11 staff, 4 of them went on maternity leave within the first 6 months. So anyway, so we've had a lot of the staff are young, energetic, dynamic, enthusiastic females in their late 20s and early 30s. And so, you know, like that's what I did when I was, you know, I had 3 children in that age range at that time, you know, so this has been a challenge for the service. But what it has shown is that in one of our areas, our key worker went on maternity leave, and we had no one to come in and fill that gap. And then that's been going on for about kind of 9 months, and we've been trying to cover it in all sorts of mishmashy ways, but they're not good enough. And so I had a meeting with the 2 consultants in that area, and essentially they said to me, oh my God, we see such a difference. So there's one cohort of their patients who have access to a key worker. She has 20 something cases. She can't take any more cases. They were like, we have this other cohort of people who are now on a kind of a quasi wait list, half being, you know, getting a bit of this and a bit of that, but they're not getting it. They were like, it isn't good enough. We're not retaining those people. We're losing them. You know, they're lost to follow up. They're not engaging in any of the other interventions, it turns out, because they're not getting the key working. And so that's probably the thing that's what I've had back to me. So they actually met, and we've been trying to prioritise getting the key worker bit covered actually. And now, so it's happening, we're co-working them with members on that team who would never have key worked before. And that's kind of how we're doing it. And it's because the team see the value of it. So that doesn't quite answer the question, but it gives you something. Yeah.
But it is really helpful. The key working relationship so important. It really is. And I think you can't, unless you've got people engaged in services, you then can't deliver the effective interventions. So it has to be the engagement, and they just get lost to follow up in our services. Yeah. Okay, that's great. Thank you. There's another question about is there access to the co-produced training modules?
Oh yeah. So now they were developed with the College of Psychiatrists. So I actually have asked that question because I've wanted to share them outside of that, and I still haven't gotten an answer on it. So I don't have access to them currently. Yeah, because we co-developed them with the college. They had the technological resources to help us do it. But I don't have ownership over them. Yeah. Yeah,
no, that's grand. Thank you. We have developed or piloted a module ourselves. It's a multidisciplinary module for NES, which is the sort of NHS training board in Scotland. And that's going to be made into an e-learning module, but was developed in conjunction with lived experience people. So I imagine there's some similarities between the modules you developed and the ones we developed.
Yeah.
There is another question here about would you buy the argument that standalone EI teams should not be starting clozapine because that's a decision for clinicians and patients and families for decades?
I wouldn't. Our biggest problem is that people don't start clozapine early enough. So I have one girl who comes to mind who was really unwell when she first presented. We worked so hard with her in the community to try and keep her out of hospital. She was on different medication, we kept trying to persuade her to go on clozapine. She really didn't want to. So 2 years in, she did go on clozapine. And honestly, the difference, I'm like, she's a totally different, she still hears voices, she still struggles with certain things, but oh my God, she's functioning so much better. And she's very clear on it herself. Our biggest problem is not getting people on clozapine early enough. Yeah. And I suppose, like, you know, if clozapine, the side effects are intolerable, people will stop it. It'll stop. It's not, you know, you're not committing them to a life sentence. But when it works, God, it can actually be bordering on miraculous sometimes. You know, and I suppose the literature would say that the more you delay, if people have had 2 proper trials of antipsychotics and they've been compliant, and they're still really struggling and they're not recovering, you know, that you'll end up putting them on clozapine at some point down the road anyway. You're actually probably just delaying it. And there's now evidence to say that the earlier you put them on clozapine, the more effective it is. So I'd be a big proponent of early clozapine, appropriately. Yeah.
Yeah, no, I completely understand that. We don't use it enough, I don't think, in our service, but some of that's because it just takes the time, doesn't it, to trial other medications and make sure compliance is there, to make sure you've had a kind of treatment dose.
No, compliance can be a big issue. Yeah.
But okay, that's really helpful. I think, oh, sorry, there's one more question. You mentioned the public awareness and stigma associated with psychosis. Do you have any ideas or recommendations for how we could address this in Scotland? I'm interested in the keyword search findings of the research you mentioned in the newspapers.
Oh yeah, so we've actually gone on to do, so Shine, who I've mentioned a couple of times that we collaborate with, within them they have an organisation called Headline, and Headline monitor the media for their use of certain mental health related terms. So, but they've largely been funded around suicide and self-harm, but they actually last year moved into the area of psychosis as well. So we're hoping to work with them to better, what they do a lot of engaging with journalists. And so we did a piece of research, it's an update on the one that I presented there, between the data they were collecting and then one of the academics in Galway, because it's that collaboration bit really helps you move on sometimes, because they had the data, but they had no one to analyse it. They collaborated with an academic group in Galway, Gary, the professor there, and then a peer support worker, Connor, and then his colleague Emmett. So they've analysed that data for the full year now. And now what they're going to do is they're going to go and do a workshop with journalists and develop some guidelines for journalists about how they could do better. So certain things they did reasonably well, but there was no lived experience in there. I think it's the lived experience. It's that piece. It's the experience. It's the experiential thing again, like convincing yourself that the change is worth doing. When you experience it, you believe it. I think if people had a better understanding of what psychosis really is and the fact that people can really recover, then I think that changes. That's the most powerful thing, because people like me and possibly you, Susie, people just shut off. They're like, oh, she's talking about her own pet area. You know, this is just her being, you know, an expert. I mean, experts are obviously bad now. So, you know, so I think it's getting that lived experience voice out there. So that's one strategy we're looking at in Ireland. I suppose you've had really big ones. I don't know if they were confined to England, but you know, time for change. Is that right?
There was quite a lot of English campaigns. We've had a sort of a campaign called See Me, which was a Scottish government funded campaign. Yeah. We're cautious as a sort of conscious as a health promotion need up here, but a little bit concerned about radio adverts and all the things they've done in Norway, because the services are not there yet to catch all those folk. Yeah. I think we've certainly had people, you know, newsletters, as you've seen, and lived experience.
You have excellent newsletters and a much better website than us. Rona, who works with me, is like, have you seen their website? Have you seen their newsletters? We need to do that. And then we looked at it and we thought, we can't do that.
So we've got some work going on, and actually you're making me think. We had plans for a television company to make a programme with us in Glasgow, and to have service users and follow them through on their journey of care and kind of promote recovery from psychosis, and have a kind of you know, a public health or public education angle to it. But actually it all got stalled with COVID, and obviously the service is under pressure now, but it's making me think we should go back and do it again and start that conversation. So there's another comment here. It's really great to hear about how much you value lived experience. I hope Scotland has this emphasis. So we're trying, Molly, definitely trying. Thank you. Is there any other questions, Karen? You've been so helpful answering the questions. There've been such varied questions there, but thank you so much for that.
It's no problem. No, and thank you for inviting me. I'm delighted to come along. It's you know, sometimes it can be really off-putting if I go to places where they've got like an investment of 1 billion and they're going to be rolling out 50 new services, and you know, and it can feel a bit like, oh God, you know, oh God, we're never going to get there, you know. But actually, that's not really how it happens most of the time, you know.
No, and I think we've got additional challenges with us, you know, the COVID consequences and demand in the system. Absolutely. And it's very much a slow start in Scotland. We're definitely trying to pilot what the rural areas will look like, and I don't think we know that yet, but it's so useful to connect with you and hear your experience and benefit from your wisdom. So thank you so much for all your input today. Really nice to see you again.
Yeah, you too, Susie. Thanks.
Thanks, Karen, and thanks, Susie. And I'll just echo that of what Susie said, Karen. It's been really, really helpful and really insightful for us to hear from you today. And I think there's a lot for us to take away for the work that we're trying to do in Scotland, and certainly would like to keep connected with you around that.
Definitely.
There's a slide up just if anybody's on the call and wants to just keep informed with the work that we are doing. You can follow us on Twitter. We've also got a website as well, which you can look at. And we have a national network mailing list where we send you updates, monthly updates on how the programme's going. And finally, I think there's a evaluation going to go into the chat box. If you have just a minute or two just to give us some feedback, it's really helpful for us to hear going forward how we can adapt these webinars or anything you might like to hear about. So thank you so much for joining us, everybody. Thanks for the interaction and the questions, and again a massive thank you to you for coming and being here with us today. It's been really, really great, and yeah, thank you very much, everybody.
Thank you. Bye.
Thank you.